somewhere, beyond traditional thinking, beyond standard treatments, is a place that bridges where we've been to where we're driven to be. It's where innovation that saves and sustains lives meets the providers who make it happen. Where our ability to manage illness expands to reach patients with limited options. Where we address complications before they become life-threatening. Where we're not only treating diseases, but also discovering smarter ways to prevent them. This is our place, where we come together to write our greatest chapter as a visionary company operating at the center of global healthcare. This is the intersection of our boldest possibilities. This is the new Baxter.
Good afternoon, everybody, and thank you for joining the nursing session this afternoon. We have a very interesting and exciting lineup for you. Firstly, I would like to start the session by just giving a definition of what a nurse is. So when we read, it says a nurse is somebody that is patient and kind, and that they have the ability to think on their feet. It is a trained professional who focuses on the needs of others. And then it goes on to expand that a nurse actually is a superhero. So all of us go to work every single day and we don't wear capes, we often wear scrubs because we are the heroes. So without delaying it too much, I would like to welcome onto the platform a nurse hero, a nurse leader. Her name is Sister Joyce Lamini, and I will just read her bio. Joyce completed a diploma in comprehensive nursing, qualifying as a general nurse, a community nurse, a psychiatric nurse, and a midwife. After qualifying, Joyce specialized and completed a diploma in critical care nursing. Her passion for her students and her mere colleagues led her to become a preceptor for post-basic ICU students. She further obtained a BECA specializing in nursing administration and nursing education. Joyce is an emergency management and severe burns management trainer and the operational manager of the Chris Hani Baragwanath Adult Burns Unit. Joyce, over to you.
Good afternoon, everybody. This is Sister Joyce Lamini, an operational manager in Chris Hani Baragwanath Burns Unit, Adult Burns Unit. Today's topic is on patients' privacy. So let's quickly go through the presentation outline. What is privacy? Why is privacy important? Rules to privacy. How to ensure privacy. Should smartphones be used in hospitals? Privacy and the use of smartphones in the hospital. And that's it. Well, today we all know that our patients are well aware of their rights and patients are well aware of their rights these days, and they seek better from medical world. And if their expectations are not met, a backlash will be felt from them. As nurses, we all know that we have an obligation to practice within the scope of practice, be competent, and act within the legal framework. That takes us back to, that makes us be aware that Nursing Council has patients' best interest at heart. We also have the duty to maintain confidentiality at all times. And that also takes us back to our nursing pledge. Remember, I will always hold all personal matters that come to my knowledge. I will maintain the utmost respect for human life, unquote. But what is it that needs to be done as nurses? we need to overcome, or we need to encourage respect. We need to make sure that there is a professional conduct and a responsive consciousness amongst us as health professionals. Why is privacy? What is privacy actually? Privacy is the right to be left alone. Today, we define it as the right to maintain control over personal information. Despite it being a fundamental human right, it is not unconditional because it is limited by the rights of others. We all have the right to freedom, but once that right infringes upon the rights of others, the court of law deems that right forfeit. Why is privacy so important? Once you provide privacy to your patient, the element of trust just creeps in and the patient loosens up and they open up to you. Assessment and history taking are the key elements to providing quality care. Privacy too has rules. So what are the rules of privacy? Privacy prohibits the sale of patients' information provided a written authorization is obtained from the individual. Patients' information can only be used for individual care. Patients' information can be shared amongst healthcare workers provided with the purpose of improving the health of the patient. Let's make an example of eminent meeting whereby the multidisciplinary team come together with the aim of improving the quality of care. Patient information can be disclosed to a family member designated by the individual. And always let's make sure that that information that is shared it's minimal. Researchers are also to get authorization before they can use patients' information. What is it that we need to do to ensure privacy as healthcare workers? We need to keep records locked, allowing access only to people who need to see the information. We need to keep electronic records secure through passwords. We need to monitor who gains access to such information. Whenever we hold discussions about the patient's information, that has to be done in private. It's important that we turn the screens away from viewing. During presentation, always remember not to use the patient's name. The important question would be, should phones be used in hospitals? Well, it depends who you ask, because science hasn't proven that to be a problem. According to literature, only 1.2% has been proven to be affecting, or has been proven to be having an effect on the use of medical equipment. Hospitals and other institutions, they all have disclaimers like do not use the phone, no videoing or no filming. But we have seen doctors and nurses using their phones within the clinical setting without them worrying about the ventilator short-circuiting down the hall. Phones can also be used to search for names of medications. Phones are also used by physicians. Phones are also used to call physicians or the charge nurse or the nurse aide. Seniors can be consulted in absentia. In this era of COVID, we have a Disaster Management Act. This act supersedes all the human rights, whereby the no visitation was dropped. And the only means of getting hold of the loved ones or being in contact with your loved ones was through the phone. Phones are the only way patients can keep in touch with their loved ones. Privacy and the use of smartphones. Smartphones are essential tools in the medical settings these days. To ensure privacy, no face of the patient to be part of the photography. Health professionals are able to view the image, respond, and advise. Senior health personnel are consulted or can be consulted in absentia. Images can be stored in a computer for future reference. Patients always appreciate receiving voice or video calls from their loved ones. And they can also be used as reminders to take medication or to attend clinics. As much as it has been proven that phones have a little or no effect on the functioning of the medical equipment, however, as nurses, we need to remember that protocols are in place for a reason. Just because we can use phones in the clinical settings, that does not we always should, because distraction is at the top of the list of concerns and it causes a major errors in the workplace. Lastly, phones are a breeding ground for bacteria. Thank you.
Thank you so much, Joyce, for a great presentation. You have tackled tough subject matter here, because we know that as much as we have to embrace technology, it also comes with its own barriers and its own limits. We just had a question from the audience where they wanted to know, do you have it written up in your ward situation that phones use should be limited, or how do you address the use of phones in your practice?
Because our department is an admission ward, we have a clause whereby we make our patients sign consent forms and explain to them that the images of their wounds would be taken for consulting with the seniors, so that they can view them and advise, even if they are not in the clinical setup at that time.
Okay, so you need to then ensure that your patients sign the consent. And then just a quick one for my own knowledge then, have you ever had a situation where, because we see in social media often that a lot of the things that are happening, one patient would be recording the other patient. Have you had a personal encounter or experience like that where a patient's personal information is shared by another patient?
Yes, we have. Yes, we have. We once had a problem. We once encountered such an ordeal whereby a patient filmed what was happening in the department and then posted that to their relatives at home. And that was a very big issue. It had to be handled by the quality department.
Okay, thank you. I'm just checking if there are other further questions. Joyce, just quickly, what was the consequence of that? How did it play out?
Luckily for us, the video was not filmed in our department, but the patient had to be the relatives had to be cancelled and then explained what was happening because it was in the midst of the COVID and everything was just new to everybody. So the relatives were reassured and all that was handled very well.
Okay, awesome. Thank you so much, Joyce. The way you guys handled it, saying that it was during the COVID pandemic, which was new to all of us, it just attests to the fact that nurses are very creative and we are on our feet thinkers. So thank you so much for an excellent presentation. We really enjoyed it, and it was definitely very current and very, very relevant, and we all learned something from it. Thank you so much.
Thank you so much, Ethan. Bye.
Okay, thank you. Bye. All right, so we are going to go and play a pre-recorded presentation just now. Can we then just start the presentation?
This video will help guide you through the steps to prepare your Tecile fibrin sealant for use in surgery. Tecile fibrin sealant comes in two different sizes, a 2 ml and a 4 ml. You can easily identify the size by the labeling on the side of the packaging. It will either be a green 2 ml or a red 4 ml. To mix Tecile, switch on the amber switch of the fibrinotherm machine to heat it to 37 degrees. Each Tecile kit consists of a small box containing the active ingredients. Human fibrinogen, which is in the blue capped vial and placed in the machine on the side indicated by the blue arrow. Synthetic aprotenin, which is the clot stabilizer. Human thrombin in the black capped vial and placed on the side indicated by the black arrow. And calcium chloride, used as its solvent. In the large box in the kit is the Duploject system. The system consists of two packets, packet A and B. Packet A is for use in the non-sterile field and packet B is for use in the sterile field. Packet A consists of 2 syringes and 2 needles. The blue scale syringe is used to reconstitute the fibrinogen with the aprotenin, and the black scaled syringe is used to reconstitute the thrombin with the calcium chloride. The golden rule of mixing Tecile is always mix blue with blue and black with black. Open packet B for the scrub to use in the sterile field. Start mixing when vials are heated to 37 degrees as indicated by the small amber light going off on the front of the machine. Remove the caps from each vial and clean the stoppers with an alcohol swab or Webcol. Now use the blue scaled syringe to draw up the aprotenin from the small blue capped vial and inject into the freeze-dried fibrinogen. Discard the syringe and needle. Make sure the fibrinogen is soaked. Place back in the machine. Time 5 minutes and switch on the stirrer or the green button. Now taking the black scaled syringe, draw up the calcium chloride out of the black capped vial and inject into the freeze-dried thrombin. Discard the syringe and needle. Make sure the thrombin is soaked. Place back in the machine, no mixing necessary. After 5 minutes, switch off the stirrer and allow it to stand for a while. The fibrinogen solution appears clear and viscous. The thrombin solution also appears clear. When the scrub sister is ready to draw up the Tecile, clean the stoppers again with an alcohol swab or Webcol and start with the fibrinogen. The scrub sister will use her blue scaled syringe and needle to draw up the fibrinogen with the beveled side of the needle flat against the glass. Draw up slowly to minimize air bubbles. It might be difficult to draw up as it is viscous. Using the black scaled syringe, your scrub will draw up the thrombin solution, making sure to get rid of all of the air bubbles and making sure the volume in each syringe is equal. To assemble the dupliject, place the blue scaled syringe on the left side of the dupliject. Make sure the wingtip of the syringe and the plunger tip fits into the grooves. Because the black scaled syringe is equal in volume, it will slot easily into place next to the blue syringe. Always make sure never to handle the dupliject at the back of the plunger so as not to expel the Tecile accidentally. Always handle in the middle on the sides. For dripping, affix the applicator to the top of the syringes. Use the strap to secure it to the red button on the dupliject. And now twist on the needle cannula and remove the cap. The Tecile is now ready to use. Once mixed, Tecile can be kept for 4 hours. Expel the first drop or two on the draping to get rid of any potential air bubbles. Once applied, Tecile starts polymerizing within 10 seconds and is complete after 2 minutes. It reaches maximum strength after 2 hours. To spray Tecile, the spray set is extra and not included in the kit. The spray set is open for the scrub sister to assemble in the sterile field. The spray set contains its own applicator with a blue dot at the front to indicate where the fibrinogen goes. Attach the applicator to the syringes as previously demonstrated. There is a connection to aerosolize the Tecile at the back of the applicator. The spray set has 2 sides. The white and blue ends are returned to the floor or circulating nurse to attach to the easy spray machine used for open surgeries. The red and clear end is attached to the dupliject. Attach the clear tube to the back of the applicator and slide the red foot into the tracks at the bottom of the dupliject as shown. The hose of the Easy Spray machine has a special adapter, and this will only fit into the medical air vent, which is black and white, in the wall or arm coming out of the ceiling. Once plugged in, switch on the machine. The pressure gauge should always be between 1.5 and 2 bar. There's also an easy reference on the machine showing pressure and spray distance from the tissue. The blue and white end of the spray set is attached to the corresponding air vents on the machine. You are now ready to spray. Position thumb over the hole at the back of the dupliject. Keep 10 centimeters away from the tissue. Applying slight pressure, spray a thin film moving from side to side with a smooth wrist action in order to coat the entire area. Reapply if necessary.
Thank you, Giselle, for that presentation. Yeah. So it was very informative and very practical. And yeah, you know that we like practical things just to make our lives so much easier. So I'm going to hand over the floor to you.
Thank you, Sister Andrews. I appreciate it. I just want to introduce myself. I am Giselle Barlow, and I'm in the Advanced Surgery portfolio for Baxter Healthcare, and I'm the Tecile product specialist in the Western Cape. So I'm glad that you found the video very informative. I just wanted to say that Seal is Baxter's fibrin sealant, and it was launched 43 years ago and is still growing strong due to the constant innovative product development that we're doing, and also the new methods of applying the Seal, which is now open and laparoscopic spraying as well, where previously it was just the dripping application that we had. Seal, like you saw from the video, consists of human fibrin and thrombin, which mimics the last stage of a coagulation cascade to form a clot. And it doesn't need your coagulation cascade to function in order to do that, which is why Seal is known as an active hemostat versus passive hemostats, because it has the human fibrin and thrombin, where your passive hemostats do not have thrombin and is more like your potato starch powders, which will only function if it has an uncompromised coagulation cascade. So as you saw from the video, Seal offers 4 features. It is a hemostat, it is a sealant, which minimizes the occurrence of seroma formation. It's a glue, which you can use then in skin grafting in burns patients, and also for grafts in pterygiums, and it also aids in tissue repair, which then very practically talks to 3 of your surgical challenges in theatre, which is usually your bleeding, your healing complications, and your leakage. So I hope that it was informative and just taught you a little bit more about Seal. And if there are any questions, there is a Seal representative in each area. Please feel free to contact them. They will be more than happy to assist.
Awesome. Thank you so much. And then I would also just like to encourage everybody, if you have got any questions, to visit the booth. There will be somebody there on the live chat that can answer it. So you don't have to wait necessarily till you get back into practice to speak to your representative. There's somebody available at the breakout sessions.
Definitely.
Right. Thank you, Giselle.
Thank you very much.
All righty. Okay, so as we continue with the program, I would just like to read you a quotation. It says, "As a nurse, we have the opportunity to heal the mind, the soul, the heart, and the body of our patients and their families and ourselves. People may forget what we said, they may forget our names, but they will never ever forget how we make them feel. And now, because our patients that has burn injuries are not always just the injuries, sometimes they come to us with comorbidities. I would then like to introduce our next talk, which is then presented by Ms. Cassie Purvey, and the talk is on diabetes and burn patients. Okay, Cassie is a registered nurse who commenced a career as a senior specialist burns nurse in Australia in 2002, where she, with her love for wound care, began. Over the 19 years, her career in healthcare expanded throughout the many clinical areas within adult and pediatric settings, including cardiothoracic intensive care, neurosurgical, neurovascular, orthopedic, and trauma units, long-term care and rehabilitation centers, and specialized home care services. Currently, Cassie works as a clinical coordinator for tissue viability and stoma care in Amana Healthcare, where she oversees a large specialist tissue viability team that provides an advanced wound care service in a variety of clinical settings in the United Arab Emirates. So Cassie has sent through her presentation, and then we will then hand over to the studio.
Good afternoon, everyone. My name is Cassie Purvey, and I'm the Tissue Viability and Stoma Care Coordinator at Amana Healthcare. Today, I'm just doing a short presentation on diabetes and foot burns. So the aim of this presentation is to give an overview of the incidence of diabetes and foot burns, to discuss the extensive assessment that should be undertaken when caring for a patient who has sustained a foot burn or any foot wound, and subsequent management of these burns. It will also give insight into the impact diabetes can have on wound healing and the careful monitoring that is required to help prevent further complications. It will also emphasise the importance of patient education and awareness in the prevention of foot burns. So a brief introduction to diabetes. So diabetes is a chronic, persistent, long-term disease that occurs either when the pancreas does not produce enough insulin or when the body cannot effectively use the insulin that it produces. Subsequently, it can then damage the heart, blood vessels, eyes, kidneys, and nerves. So when a burn injury is sustained to a lower limb, it can have catastrophic outcomes for the patient due to the challenges in healing these wounds. In 2019, the World Health Organization showed that 10% of the adult general population suffered from diabetes, which was approximately 463 million people in total, and 4.2 million deaths were directly due to diabetes. Locally in the UAE, where I currently practice, the International Diabetes Federation indicated that 1 in 5 people in the UAE suffer from diabetes, which is the 10th highest incidence in the world and affects greater than 1 million people across the UAE. So this can be largely due to the lifestyle that's here. It's very easy to access fast food delivery, the hot climate for a lot of the year, which can make outdoor exercise and activities a little bit more challenging and can lead to a sedentary lifestyle. So it emphasises the need for ongoing health education in the region. So causes of foot burn. So diabetic patients, due to their neuropathy and poor circulation in their lower extremities, can feel coldness in their feet and subsequently can try to warm them using hot water or heating devices such as wheat pads or hot water bottles. Their insensate condition can quickly lead to burning of the skin due to the neuropathy, and the outcome can be devastating, with them sustaining deep dermal or full thickness burns. Some other scenarios are people who are walking barefoot over hot or cold surfaces, and this can lead to injury with either burn or frostbite occurring. These patients can feel less pain as compared to a non-diabetic patient due to their neuropathy. So therefore, they might presume the burn wound is not deep or critical and thus delay medical attention afterwards, which can lead to further complications. The hot outdoor lifestyle in the UAE poses a unique critical profile for foot burns, which the burn injury mechanisms across seasons differ and different patient subgroups. So for a very small percentage of total body surface area burnt on feet, it can have significant effects on morbidity and affect function and mobility. Interestingly enough, there was a local study that was conducted in Saudi Arabia by Al-Qatan. It studied the incidence of foot burns during Friday Mass. So 12 cases of foot burns were sustained because of walking or standing barefoot on the street following Friday Mass. All injuries occurred during the summer months when the ground temperature was estimated to be between 50 to 60 degrees. There were 2 children and 10 adults in this study, and 8 out of the 10 adults were diabetic with significant peripheral neuropathy. So the injuries sustained were deep burns to the entire sole of the foot due to the lack of sensation. Assessment of foot burns. So a thorough comprehensive assessment should be undertaken for any diabetic patient who sustains a foot burn. This is important to establish an effective treatment and management plan to help minimise any complications and promote effective healing. The assessment of a diabetic foot should include looking at the wound, so the location, size of the wound, depth of the wound, necrosis, exposed bone, joint or tendon, any edema and where the edema is, exudate and the type of exudate as well, and any clinical signs of infection and sensation that may be present. This can be obviously challenging with diabetic feet, as if there is neuropathy present, burn depth assessment often involves pain assessment. So if they can't feel their feet before the burn happened, it's very difficult to use that to assess the depth also. Dermatological assessment of the feet, so skin changes, sweating, nails, deformities that they might have, muscle wasting or any blistering that has occurred. And musculoskeletal assessment of the feet, so looking at the deformities and gait of the patient. So the presence of motor neuropathy can cause atrophy of the small foot muscles that lead to deformities such as clawing of the toes, and this can obviously impact the patient's gait significantly. A vascular assessment and examination should be performed of the lower limb, which includes assessment of pulses and looking for signs of peripheral arterial disease or venous insufficiencies. Peripheral blood flow can be impaired with these patients due to atherosclerotic changes in the distal arteries or increased blood viscosity from hypoglycemia, which can also lead to ischemic changes. Blood flow to the lower extremity may be monitored with use of a Doppler ultrasound or ankle brachial pressure index, and a close assessment of the circulatory status should be maintained throughout the treatment for this patient. The formation of edema that can occur post-burn injury can also cause constriction and occlusion of blood flow, which can lead to gangrene of the lower extremity also. This is observed a lot more frequently in circumferential burns, so it's really important to assess if the wound is circumferential to the lower limb. Something that I use quite regularly in practice is also the use of pulse oximetry, which is helpful in determining the oxygen saturation to the tissues. And then also assessment of peripheral neuropathy. So monofilament testing is important to establish if the patient is neuropathic. This can help establish the patient's care plan, especially after discharge, as they can be high risk for another injury in the future. The patient will also need customised shoes to be developed to reduce the risk of pressure damage and friction and shear. Another important assessment is the cardiovascular examination and assessment of diabetes control. So the blood glucose level and HbA1c are all very important to give you an idea of the patient's current health status and help you to establish the need for referral to cardiology and/or endocrinology. So due to the high risk of further complications, correct identification of the foot burn and immediate referral to the local burns unit is essential if you are looking after the burn in the community. So there might be telehealth support for different burns units via video conference or teleconference, depending on the local protocols that can help provide specialist supports for these patients. So the impact, the neuropathy, neurovascular disease, uncontrolled blood glucose and infection are factors that can lead to severe complications, morbidity, amputation and mortality with diabetic patients that sustain a burn injury. Delays in receiving proper treatment and wound infection can worsen this process too. So diabetes can have an adverse effect on healing processes in many ways. Such as a lot of diabetic patients may have vascular issues, including macro and microvascular problems. So we all know that a wound that doesn't have adequate blood flow is very challenging to heal. So delays in wound healing also can have an increased chance of infection and scarring. So obviously with these delays in wound healing and potential long-term scarring that occurs, this can have a profound negative effect on the patient's psychological well-being as well. Patients may also have a renal function impairment due to long-standing diabetes, and the uremia will delay the healing process because the urea toxins, they can reduce the production of granulation tissue and neurovascularization. As we've mentioned before, a lot of patients who sustain foot burns suffer from neuropathy, and the lack of neurofeedback can flatten the arch of the foot. This results in increased pressure over metatarsal heads and uneven distribution of body weight over the foot. So it can cause excess pressure in one area, and that can delay the healing process. As you can see in the top right-hand photo there, that's a neuropathic foot with some very unusual pressure points that occur. Patients can also have a lack of sympathetic nerves that can impair sweating, and it can result in general dryness and cracking of the skin of the foot. This can cause fissures that can be the site of entry for bacteria and subsequent infection. Nerve function impairment also reduces the level of neuropeptides in the tissue, and they decrease cell proliferation around the wound, which can also contribute to wound healing impairment. Also, neuropathy and hyperglycemia can lead to impaired local immune system function. So the lack of blood sugar control can lead to hyperglycemia, which then induces the production and release of cytokines. These impairs the inflammatory response in the tissue and can also lead to delays in wound healing. And subsequently from this, the infection itself can increase the resistance to insulin, and then that can cause subsequent high blood sugar levels, and the cycle continues. So as you can see, the successful management of foot burns can be very complex and very challenging to heal. Some other impacts from foot burns with diabetes is the increased length of stay. So due to the risk and incidence of ongoing complications, these patients can require extensive medical support to recover from their injuries. This can then lead to ongoing lengthy stays in outpatients or home care settings for long-term wound healing and rehabilitation. The risks of complication from amputation, so due to the complexity and multi-organ impact of diabetes, often the patients experience extensive complications, and this can then lead to amputation or an increased risk of mortality. So delays in seeking medical review when the injury occurs. Often the patients present with an already infective burn wound, and it's an uphill battle to try and salvage the limb. So impact on patient wellbeing as well. There's been many studies that have shown the long-term impact of patient wellbeing and psychological health with the lived experience of a chronic wound. Reduced mobility and confidence to perform activities of daily living, long-term pain and acute pain, ongoing wound care, and costs associated with the medical care can all lead to devastating outcomes for the patient wellbeing. So management of foot burns, it's really important due to the complexity of these patients to ensure that you have a really thorough multidisciplinary team established. So the multidisciplinary team management focus on the model of holistic care that addresses to the medical comorbidities, the burn injury, and functional return to living. All patients with diabetes who experience foot burns require optimization of glycemic control, and this may require a referral to endocrinology. This will also need to work closely with the dietitian to help navigate a healthy diet, but also optimal protein to support wound healing whilst maintaining optimal blood sugar level control. Physiotherapists and occupational therapists are actively involved in rehabilitation for mobility, scar management, and ultimately return to work. So as you can see, each member of this team plays a crucial role to ensuring that the burn is appropriately managed and minimal long-term complications occur. So surgical management, the glabrous skin on the sole of the foot is very difficult to reconstruct after a severe burn injury. It has a thicker epidermis and a compact, less elastic dermis, and is also cushioned with a fat pad. This makes it more resilient and able to withstand force, pressure, and shearing. And the plantar skin also lacks hair, sebaceous glands, melanocytes, and it's very similar to the palmar aspect of your hand. For this region, very careful surgical consideration needs to be undertaken to ensure adequate healing of the wound and reduce the risk of contractures and reoccurring wounds in the future. On the other hand, the skin on the dorsum of the foot is thin with minimal subcutaneous tissue. It protects and allows for gliding movement of the extensor tendons. So burns to this area can be difficult to manage due to the risk of tendon and bone exposure, tendon damage, and scarring. A burn injury can also cause adhesions affecting the function of the tendon, which makes this very difficult to manage as well. So the skin structure overlying the malleoli also lacks subcutaneous tissue. So an injury to this region can very easily be devastating and expose structures of the ankle joint. And once you expose joints or tendons, this significantly increases the risk of infection and serious complication, and can ultimately lead to such things as amputation. So local wound management goals. So optimal burn wound management should involve cleansing and removing of non-viable tissue, infection control to prevent any infection occurring with the wound, creating a moisture balancing environment, especially important with tendon involvement to make sure that the tendons remain moist as well. Pain management, obviously, initially, if they do have neuropathy, there may not be acute pain experience, but obviously reconstructive pain with surgery can occur. Minimizing, obviously, bacterial colonization, reducing inflammation and promoting reepithelialization. Of most importance also is being able to ensure adequate pressure offloading to the burn area so that there is no pressure on the wound that you're trying to heal. This will also help prevent further trauma. A very important aspect also is to ensure that the dressing is in contact in between the web spaces of the toes to allow for full separation. This aims to prevent any maceration and ulceration of the skin that may occur due to the location of the wound. Risk of further complications. So preventing complications during healing is important to preserve normal biomechanics and reduce morbidity after severe burns. Vascular insufficiency and peripheral neuropathy can affect the ability to recognize pain or injury to a healing wound and can predispose a patient with diabetes to unnecessary mechanical trauma as they start walking again post-burn injury. So how do we stop these injuries from occurring? Is obviously prevention is the key, and patient-centered care is of paramount importance to this. So the lack of sensation in peripheral neuropathy obviously can lead to significant burn injury, and it's important to educate the patients and raise awareness, particularly during peak seasons of summer, with referral to supporting services as needed. So the lack of sensation that these patients may experience can often lead to delays in recognising the initial burn injury, and then this subsequently leads to delays in medical treatment and increases the risk of infection and further complications. So it's really important to encourage these patients, once they've healed from their burn injury or in a preventative measure, to do daily foot screening. So key discussions are wearing adequate foot protection, especially when outdoors or near any hot food or drinks. Emphasize about using footwear, especially on beaches or hot pavements, as it doesn't take very long for a severe injury to occur. Using moisturizers to dry feet to prevent fissures and keep the skin in optimal condition. Apply only to the heels. Don't cut any corns or calluses, and to regularly consult with podiatry. Washing and drying their feet regularly, especially in between the toes. Wearing comfortable and well-fitting shoes. If they do have any form of deformity, they should have a custom-made shoe done for them. Always checking bath and shower water temperatures so that they don't suffer any scald injuries, and avoid sitting too close to campfires, heaters, fireplaces as well. Educating the patient to understand the risks of it is of extreme importance to help minimise the impact of any injury. So all patients should be encouraged to undertake daily foot assessments, use a mirror if they have to, and to act quickly without any delays. Encouraging patients to have a clear ongoing plan for the management of their diabetes is also really important. This will be in collaboration with the GP and endocrinologist. So this is important during the healing of the burn, but also post burn injury to reduce complications later in life. The need for ongoing vascular assessments. So for patients that have been identified with poor peripheral perfusion, it is important to establish regular screening program to minimise any complications. So this can include regular blood flow assessments with Doppler or ankle brachial pressure indexes, and then referral on as required. So in summary, obviously patient education is the key to prevent these. Careful ongoing assessment with the patient. The patient needs to recognise the importance of maintaining happy, healthy feet, and this involves a multidisciplinary team, including GPs, endocrinologists, cardiologists, podiatry specialists, nurses, and therapists. And that is it. These are the references.
Thank you, Cassie, for an amazing and very interesting talk. Often when we are dealing with patients, we need to remember that we need to assess the whole patient. Just because a patient is diabetic doesn't mean that they can't burn. And just because they are burnt, it doesn't mean that they are not diabetic, and vice versa. So I just would like to then also highlight the fact that you kept speaking about the multidisciplinary team, and that patients generally can't be treated in isolation or in silos, because each member of the team has a role to play. And then also the practical hints that you have given is it's definitely something that we can remember, that we need to make sure that we look, listen, and feel as we have been trained in nursing to do, but just to make sure that we don't miss anything and manage the patient's diabetes, but also then take care of the burn. The next speaker I would like to introduce you to is affectionately known as Dr. A. He is Dr. Jose Tarrega, and he is joining us from the United Arab Emirates. Jose Tarrega is a nurse for more than 13 years and is an educator in professional development, an advocate currently in the UAE. He holds a PhD in education, 2 master's degrees in nursing, and professional development diploma in healthcare administration, and a BSN degree. He is a certified professional in healthcare quality and a certified nurse educator. He has published and has spoken in international conferences. He was awarded the Health Professional of 2019 award at the Filipino Times in the United Arab Emirates, and was one of the scholars of the Nightingale Challenge by the Sigma Theta Tau International Honor Society of Nursing. Dr. Jose, thank you for your presentation. And it's important that we as nurses remember that our careers can extend further than bedside nursing. So we're very honored to have you in our presence. Thank you.
Thank you very much, Dr. Andrews. And I would like to thank as well the organizing committee for inviting me to be in this Congress today. So for my session, I'm going to be talking about how we can craft a better version of ourselves, and basically how are we going to embark on our journey to professional development. So in the next 15 minutes or so, we're going to look into the definition of professional development, and then what are the strategies that we might be able to use when we want to start our professional development journey. And then we're going to discuss how are we going to apply these strategies in real life. I just would like to declare that I don't have any financial disclosure or conflicts of interest with the presented materials. Okay, so when we were kids, I think one of the most common phrases that we've been saying is that when I grow up, I want to be somebody. So I want to be an astronaut, I want to be a doctor, I want to be a chef, or I want to be a flight attendant. And I would presume that majority of us here would want to be a nurse, because we're here now in a nursing congress, right? So before I start, I just would like to share a snapshot of my professional development journey as well as a nurse to becoming a nurse educator. So in 2008, I completed my bachelor's degree, and then I earned my license as a nurse to practice in the Philippines. And then eventually in 2019, I worked in a tertiary hospital in our region. And then because the condition of nursing back home is quite challenging in terms of the financial side, I've decided to look into moving or migrating to a different country. So I found an opportunity in the Middle East. So in 2013, I moved to the UAE and worked as a staff nurse in a long-term ventilated unit. And then in 2014, I had the opportunity to be promoted as a charge nurse. And then at the time as well, I started my PhD degree in development education. But then something happened in 2015, and I ended up getting demoted from being a charge nurse to a staff nurse. So at that point, because when I started as a staff nurse, I considered moving into the leadership and management pathway, but it seemed like it didn't work for me because in 2015 I was demoted. So I entered into I think a short period of depression, I would say, and then eventually I was able to pick myself up. And then in 2016, there was an opportunity to work as a clinical resource nurse, which is tantamount to a clinical educator. So when I applied for the post, I was informed from the get-go that I will not be given the actual post, mainly because I was not Western trained. I was Asian. So nevertheless, I took the chance because I was really interested to teach. And eventually, on the year 2017, I found another opportunity in another facility, and they offered me the job of a clinical resource nurse. And then while I was doing the job, I've been very active in my community here, the healthcare community here, giving continuing education for other healthcare professionals, and then volunteering to teach in some other non-government organizations. So eventually in 2019, I had the privilege of getting the award as the Healthcare Professional of the Year in the UAE from the Filipino community. And then in 2020, I was able to complete my PhD, and I was given the chance to work to be a scholar of the Sigma Nightingale Challenge. And I found a new job as well, which is the current job that I'm working now. And then in 2021, I was able to find opportunities for scholarships as well. So I got accepted in Duke University to work on a certificate in nurse leadership, and in Harvard Medical School for a trained to teach in medicine program. So 2022 is still coming. So I'm not so sure as to what is going to happen in 2022, but I'm definitely going to pursue my path as an educator. So if you look at my timeline in terms of my professional development, and I think everyone would agree, was for those who have been in the nursing profession for quite some time, because I've been a nurse for 13 years now. When you embark into your journey for professional development, there are different pathways that can, or there are different circumstances that might happen, and you might be rerouted from one pathway to another, just like what happened to me. So I've always thought that I'll start in the leadership and management pathway, but then I was rerouted to education. And so far for now, I'm extremely happy with what I'm doing right now. So this is the reason why I would want to share some of the strategies that I've used and that I've discovered as I've embarked in my journey for professional development. So if we ask ourselves, or if we ask everyone here, what is professional development? A lot of you might define it differently. So some would say professional development is more on pursuing postgraduate studies, taking up your master's, your PhD. Some would say it's generally learning something new. It could either be relevant or not related to what you're currently doing. Or it could be getting certification. So if you're a nurse and you are subspecializing into a specific specialty, you might, for example, as a healthcare quality professional, you can get a CPHQ or a certified nurse educator or a certified infection control nurse. So there's a lot of certifications that you can get as well. And it could also be landing a new position or a new role. But the bottom line is, if we talk about professional development, it is basically growing into who you want to be as a professional. And there can be different definitions, but if we look at a more formal definition of professional development, according to Chartered Institute of Personnel and Development from the UK, it is a combination of approaches, ideas, and techniques that will help you manage your own learning and growth. But from my personal perspective, I believe that professional development, it is a continuous process of building your competencies. You enhance your knowledge, your skills in your specific field of interest so that you can maximize your potential. And there are a lot of considerations in terms of professional development, because we have to remember that it is a conscious process, which means then that it is intentional. You do not just develop by accident, because you have to make the decision that you would want to grow, or you would want to change or improve something, right? And another thing to consider is that when you embark on your professional development journey, it will definitely take time, effort, and even finances. So we get lucky sometimes if we get scholarship, but for most of the time, if you don't have scholarships, or if you don't have a good network that can guide you as to how you can achieve or how can you get some scholarships, you might have to spend a lot of money. So how do you achieve professional development? So from a general perspective, you can go for formal educational activities. You can have your workshops, you can go to a school or specific trainings, right? And then in terms of informal approaches, you can be mentored by somebody in your workplace who have the same interests as you are, or who specializes into something that you are interested on. Or you can conduct self-directed study. And I think nowadays this is very common, because of COVID, there has been a lot of available online courses that you can enroll yourself in. So it somehow COVID in a way provided the transformation in terms of accessibility of training materials. So the next question might be for most of us, how or where do I start? So I do understand that we are having a mix of attendees this afternoon, and maybe some of you might be new to the profession, or maybe some of you might be mid or late career nurses, But then the thing is, even if you're a mid to late career nurse, you might be at a point in your career wherein you're thinking that maybe I don't want to be in bedside anymore, or maybe I would want to shift into another career path. Okay, and that's okay. That's purely okay. So I would like to share now the strategies that I've utilized and I've sort of discovered as well while I move into my professional development path. So my ABCs include A, which is assessment, assessing and reflecting on what you really want to pursue. So most of the time when I have conversations with my colleagues, so when I do my rounds as an educator and then I have random conversations with colleagues, I usually ask them, where do you see yourself in 5 to 10 years? And most of the response that I will get is a blank stare, because I think most of us usually expects this question during your interview, right? But then if you come to think about it, if you actually have that regular conversation with yourself as to where do you want to go, that will help guide you as to what do you want to achieve. So sometimes it's very difficult as well to have it, because for example, if I ask majority of you, like, what do you want to achieve? You will just say that maybe, well, I have achieved already being a nurse or being a manager or being something in my specific field of interest, right? But then again, is that really what you want? Is it really aligned to your life's purpose? Or is that really your why? Because things change around us. So that's why it's always good to look for your purpose. Okay, so from my perspective, and I'm not saying that I'm very good at this in terms of finding my ikigai. So I would encourage everyone to start looking for your ikigai. So ikigai is actually a Japanese term that means looking for your life's worth, meaning, or purpose. Okay, so it's ikigai is your reason to get up in the morning. Ikigai is your why. Okay, your life's purpose. So according to the concept of ikigai, there are 4 quadrants, or there are 4 spheres or 4 questions that you have to answer so that you can find your life's purpose or your ikigai. So first is, what do you love? What are you good at? What the world needs? And what can you be paid for? Okay, so if we go one by one, so when we talk about what do you love? So this could be something that you really enjoy doing, something that gives you joy when you are doing it. And what is something that you are always drawn to, okay? Because again, it gives you joy, okay? So, for example, from my side, it gives me joy when I'm teaching or when I'm sharing information with others or when I'm coaching or mentoring. So that is my what do you love sphere, okay? Another sphere is what are you good at, okay? So when we talk about what are you good at, these are the skills that you are very well versed in doing, okay? So what do people look to you for help with? Okay, so when people ask you for help, what is it that they usually ask you? Because that means that you are good at it, right? So for example, if I'm just taking myself as an example. I feel like I'm good at teaching and I'm good at sharing and I'm good in explaining things. Okay, so that's why so as what I mentioned earlier, what I love is teaching, knowledge sharing, and then I'm good in teaching as well, or helping others understand specific concepts. Okay, so that is what I'm good at. And then what does the world need? Okay, so when we talk about what does the world need, what is it that when we talk about the world, it doesn't necessarily mean that the entire world. It could be your immediate community or the people around you. So what do these people surrounding you need for now? So for example, for me, I would say that maybe my community needs nurse educators to train the new generation of nurses, right? And then what can you get paid for? So for me personally, well, I can, as a nurse educator, I can get paid for being a nurse educator or for teaching in the clinical area or even teaching in the academe. Okay. So if you are able to answer the four spheres in your ikigai, you would have found your mission, vocation, profession, and your passion. Okay. So the only thing that we have to remember, because it's easier said than done, find your ikigai, find all these things. This actually necessitates a lot of self-introspection or reflection, because you need to really dig deep as to what are the things that you really love, what are the things that you're really good at, and what the world needs, okay, or what can you be paid for. For some, maybe it comes, finding the ikigai might come in an hour of reflection. For some, it might take days, weeks, or even months, okay? But then the only thing is that once you find your ikigai, I think from my perspective, if you find what is your purpose in life, it will be amazing to do something, right? Like if you're doing something in your life that is aligned to your life's purpose or vision, then you will not feel that you are burdened with what you are doing. It's like not working at all, because you are enjoying what you are doing. Okay, so that's why the first thing is to assess what do you want to do in your life. Okay, so that's your A. And then B in my ABCs is building a smart and tangible plan. So let's say, for example, that you have already discovered your ikigai. Okay, so this is my life's purpose. This is my goal now. Okay, so you build a smart and tangible plan. So I think everyone is familiar with the mnemonics SMART, right? So because everyone has used this one during our nursing years. I think everyone is still using it now when we are making our nursing care plan. So first, you have to make sure that it is specific, your goal is specific, and then that you can measure it, or that is quantifiable. It is attainable and achievable. Okay, so do not make plans that are not achievable, of course, because you are bound to fail. And then it should be something realistic, okay, and related to your interests. And it needs to be time-based or time-bound, okay? Because if you do not put a time aspect or time element in your plans, you will not know when are you going to evaluate your plans or your goals. And I would always encourage everyone to write it, to visualize it. So this is me with my short-term and long-term goals, because I have made it a habit actually since college to write my 2 years, my activities, my goals for the next 2 years and the next 5 years. And I always believe in visualization, the power of visualization and the power of the law of attraction. So what I'm doing is that my goals, I always put it near my mirror, because we always go to I'm not so sure about you guys, but for me, I always go to the mirror before I go to work. And then if you put something near your mirror, then that means it will be very visible to me at all times, right? It will keep reminding me as to what are my goals. So based on my experience as well, having my goals being written and being visible, it helps redirect me back to what I would want to pursue, because there will really be times that you will feel tired, and that sometimes you might be, you might be swayed away from the path that you would want to follow because of the different circumstances that you might encounter. So in a way, having this goal visible, then and sometimes maybe subconsciously, it just reminds me that, okay, you have to do this because this is in alignment to your goals in life. Okay, so I would really encourage this one. And I've even read one article. I think there was a study conducted by the Harvard business. I'm not so sure about, but it's a study from Harvard that states that there were when they conducted a study of students who have written their goals, those 3% who wrote their goals 10 years before became more successful than the 97% who did not write their goals 10 years after they conducted the study. Okay, so that really shows that somehow, writing and making your goals and plans in life tangible is quite effective. And of course, when you have a lot of goals, it also helps to write an action plan. Okay, as to how are you going to achieve your goals? Because if you do not have a clear action plan, again, you might be swayed away from the path that you are trying to embark on. So let's say, for example, if you want to lose weight, your actions might be, you're going to do exercise, you're going to do your diet, and then your timeline will be for 2 months, like from November to December. And then responsible persons, you have to remember that when you are making some plans for goals, it doesn't have to be only you all the time. So it could either be you or anybody that can help support you achieve your goal or plan. Okay, so let's say for losing weight, you might need a coach, right? Or a dietitian or a nutritionist that will help calculate your caloric intake or caloric need. And then after your timeline, then you can evaluate the status. Has it been achieved? And if it's not achieved, then you might write the remarks as to what were the issues that I was not able to achieve my goals, and then how can I make sure that I will be able to achieve it next time, right? So that's your B, building a smart plan. C is creating a list of priorities and learning when to say no. Okay, so this is me. SpongeBob is basically me before, when like once you try listing all your goals, there is a tendency for us to just try to embark on all those goals all at once. Okay, but you have to understand that as much as some goals are actually doable simultaneously, it's also a bit challenging to do them all together, because there is a tendency that you might get overwhelmed. Okay, and this is the reason why it's always helpful for us to have a list of priorities. Okay, so when we talk about prioritization, majority of you might have different ways, right, of prioritizing, because you consider different factors as to why is this my priority, why is this not my priority. But if you don't have your own structure of prioritization, I would suggest the use of the priority action matrix. Okay, so with priority action matrix, you prioritize your goals based on its impact and the effort that you'll have to exert to achieve your goals, right? So for example, as you can see here in the matrix, you can actually sort of compute it. You have to list all your goals, and then you score them. Let's say if you score them from 0 to 10, 0 will be low and 10 will be high impact. And then in terms of effort, 0 will be low and then 10 will be high effort. And then based on your scoring, you will then classify them either as quick wins for those with high impact but low effort, because you can easily do them. They have a high impact, but then you can do them in with a very less energy or effort. And then the major projects will be the second one in terms of prioritization, because this will be high impact for your goals, plus you need to have high efforts. Okay. Fill-ins and thankless tasks will be considered as low impact or low effort. So for fill-ins and thankless tasks, this can be tasks that can be delegated. Okay. Or if you feel that this task has really very low impact and then you have to exert a lot of energy, so why pursue it, right? Because it does not impact anyway. So that can be eliminated. Okay, so again, I think the priorities will be your quick wins because it has high impact with low effort, and then followed by your major projects which have high impact and high effort. And learning to say no is very important, because once you have done your priorities, okay, most of us have the tendency, well, at least for me, I've experienced it firsthand. I think, I'm not so sure if it's an Asian thing, but most of the time, like when people come to me and ask me for help, I just immediately say yes. But then I think over the past few years, I've gotten better in saying no in a tactful manner, of course. So the tendency is that if you say yes all the time, you will be overwhelmed, or tasks will pile up in front of you, and then you will be the one that will suffer with the consequences, because it might be counterproductive. Sometimes I even had an experience wherein I neglected my own tasks for my role because I just want to say yes to my colleagues, okay, because I want to please them. Okay, it's okay to help, of course. I'm not saying that always say no all the time. It's okay to help, but then try to base it on your priorities. So what I usually do now is that if somebody comes to me and asks for help, then I always tell them, and I'm very transparent in terms of my tasks, because I tell them that these are my list of priorities and these are my timeline for these priorities. If you need help, I'll be happy to help out, but then can that wait? Because if it cannot wait, then I'm sorry, I cannot help you out. But if it can wait, then I'll be happy to help you out. Okay, so there is a way to say no in a tactful manner that is non-offensive as well to your colleagues. So once you have created a list of your priorities, the next step will be to develop an accountability system or an accountability partner. So it's basically like going to the gym. Like when you go to the gym, most of the time, I don't honestly go to the gym, but for those who are going to the gym, I would presume that when you started, you ask for a coach, right? Because your coach or your gym buddy will help make you accountable for your action. They are the ones who will remind you that, okay, you need to go to the gym because this is your goal. Okay, you need to do this because this is your goal. So the good thing about having an accountability partner is that they will help refocus you, especially if in case you are again swaying away from the path that you would want to follow, right? So they help you stay motivated. They help you plan and strategize. Because most of the time when we look for accountability partner, it should be somebody who's also well-versed, with the specialization that you would want to pursue. And then they can act as independent observers. They can tell you that based on your observation, what you're doing is actually not aligned to what you want to achieve. And then they can remind you of your goals. And of course, they can give you advices on how to improve. Okay, so again, having an accountability partner will help you focus or refocus on your set goals for your professional development. After you have established your accountability partner, the next step will be to engage, experience, and explore. And by engaging, I mean that you have to engage with your network. Okay, so as professionals, there are a lot of professional organizations that you can join in. So, like for example, for most of you, I would presume that you're a member of the South African Burn Society. Okay, and that's a good thing because if this is your field of specialization, you can get a good network of support, good resources from that professional organization. There are a lot of organizations that you can be a member of depending on your interest. Okay, so I would suggest that you try to explore, try to look for those organizations where you can benefit from. And personally, because I'm an active member of Sigma Theta Tau International, this is the second largest nursing organization in the world. I've learned a lot from my colleagues, from the different parts of the world in terms of clinical education practice, because they have different communities within the organization. So again, in terms of the specificity of the organizations that you would want to join, just try to look for the organizations that are aligned to what you want to pursue. And then try to explore for opportunities to experience. So for example, if you would want to become a clinical educator, if there is an opportunity in your organization to become a link educator, right? Because trying those opportunities out will help you that will help you get the experience, for example, on how to do clinical education. If there is an opportunity to teach in a university, grab it, okay? Or if somebody taps you to do a clinical session, or a clinical education session, or maybe any form of teaching, grab it, because that will help provide you with your skills and experience as an educator or as a teacher. Okay, that is if you want to be a clinical educator. If you want to be a quality professional as a nurse, or if you want to be a burn specialist, then try to look for networks or maybe for organizations that can help you have that experience. It could be by volunteering, by observership, by internship, because for sure there will be opportunities for that. And then lastly, my last strategy will be to focus on the process instead of the outcome. Okay, so I'm encouraging everyone to look at the process, have the process-based mindset rather than the outcomes-based mindset. So based on my observation, the tendency for most of us is that we try to focus on what are we going to get at the end of this activity or professional development journey or something like that. But you have to remember that when you are embarking on a professional development journey, there are a lot of external factors that might or might not help you achieve what you want to achieve. So the tendency is that if you're so focused on the outcome itself, there might be, again, factors that might prevent you from reaching that outcome. And if you do not get the outcome that you wanted, the tendency is that you might feel depressed, okay? Or you might feel like disheartened, and eventually you will say that I don't want to pursue this anymore because I failed, Okay, and sometimes you even identify yourself as a failure, which is actually, not a right mindset. So this is the reason why I'm saying that you have to focus more on the process, because in each of the process in our professional development journey, we actually learn as we go along. Whatever happens, whether you fail at a certain stage or you succeed, you get lessons from that experience. Okay, and by getting lessons from that experience, you will be able to apply that and then realize that, okay, this did not work before. Maybe I can do it a different way so that I can move on to the next step. Okay, so for example, if you remember my professional development journey, if I would have succumbed into being a failed charge nurse because I was demoted to my position, I think I would not be a nurse educator now, because I would just identify myself as a failure. Okay, but then I took that experience and I tried to evaluate. So maybe I'm not really into leadership and management. Maybe I'm for another form of specialization, which worked out well for me in the end. Okay. So to recap, because I think I'm almost out of my time. When embarking in a professional development journey, you have to consider the following strategies. So these are my ABCs. First, again, you have to assess and reflect on what you really want in life. You can use the ikigai concept, or you can just simply ask yourself why. Okay, what is your why? Or even just ask, where are you now in your career, and where do you want to go? Okay, and then B is building a smart and tangible plan. Okay, so again, make sure that it's specific, measurable, attainable, realistic, and time-based. Plus, it is something that you can visualize most of the time. You can touch. Okay, it's concrete. Okay, and then you create a list of priorities so that you will not be overwhelmed, and then you will know which things to do first and which can be eliminated or delegated, and then learn to say no. Okay, in a tactful manner. And then develop an accountability partner to help you refocus as you go through your journey. And then engage and explore an experience so that you will be able to see whether things are really if you have the experience, then you will be able to have an informed decision as to whether you'll pursue it or not. And then lastly, you'll have to focus on the process instead of the outcome, so that you will get to learn things as you move forward to your professional development journey. Okay, so thank you for coming this afternoon, and I would like to welcome you all aboard your professional development journey. And I would like to end this session with a quote that a journey to 1,000 miles begins with a single step. So if you haven't done that step, do it today. And I believe that today is your first step to that professional development journey. So these are my references. Thank you very much for your kind attention.
Dr. A, thank you so much for a great presentation. I really enjoyed listening to you, and definitely what you concluded with, that we need to start your day. And I would also just like to quote George Eliot that says, it's never too late to be who you might have been. So for all of us that think we are stuck, it's not really. And then also, thank you for being so honest and sharing both your successes and your failures, because so often when we look at people that has achieved the way you have, we think, oh, it must have been an easy journey. There were no setbacks, no failures. So it gives us the opportunity to continuously recycle, develop, and improve on ourselves. So from my side, and I'm sure from the rest of the audience, thank you so, so much. I just have a question for you. When you spoke on your steps, how do you get to the different, your plan actually, you mentioned that you need to have an accountability partner. Would you say that your accountability partner is your mentor, or should it be two separate entities?
It can be your mentor, Dr. Andrew. So basically, accountability partner is just somebody that you can share your goals with and can help you remind, especially when you started to become swayed away from your goals. So it can be your mentor, because especially with mentoring, you set your contract when you are having a mentor. It could be a mentor, a good friend who is really looking after your professional development, even a family member who is really very supportive in terms of your professional development.
Okay. And what are your thoughts on mentorship in general? Because we see it's the buzzword nowadays, that mentor, but sometimes we find that if you are working in a ward situation, for instance, that the charge nurse doesn't want you to overtake her. So how does one make sure that your mentor has your best interests at heart? Do you have any tips on that?
To be honest, that's very quite challenging because I think it's a cultural thing. Different countries or different cultures will have a different perspective in terms of leadership. Me coming from the Philippines, there's always this concept of seniority. So sometimes even if you have a new staff who's very good at things, but because there is a charge nurse who has been there for quite some time, they feel like they shouldn't be overtaking me. And even if I'm trying to mentor them, but it does not. I do not see it as mentoring to succession plan. It's just mentoring for the sake of mentoring in a way. So I think the first step is to have that culture, I guess. And I know that it's quite challenging sometimes because if it's embedded in a specific organization that this is the culture that has been initiated, it might be very challenging to change that culture. But what I would say is to have that conversation as well, maybe with your mentor, that my plan to improve is actually not because I would want to step on your position, because sometimes it can be seen as a threat. If somebody is mentoring somebody, they would think that I'm mentoring somebody who might replace me in my position after a few months or something. But yeah, for me, when I was mentored by somebody, I was very honest that I'm not really after the position. I'm after the experience. And wouldn't it be nice as well, that if you train me, I will be able to help you out and help our patients and our unit and the organization itself, because you will then have somebody who knows what to do. And if in case you're not there, somebody will be able to help out.
Thank you. Thank you again. And then also for demonstrating that it can be done. You have not only spoken about it, you've also walked the talk. So thank you so much. We really appreciate your time.
Thank you so much, Dr. Andrews.
So we'll move on to our next presentation, which ties in nicely with the conversation about mentorship. And often we find as carers that we are often not cared for. But when does caring and cared for, how does one balance it? So our next presentation is titled Empathy in the Workplace, and that is presented by Pramila Thapa. So I'll read Pramila's bio for you. So it says that she has been involved in many different organizations, from founder principal to deputy dean, and then she has been appointed as part of the executive council of the university. She's been an executive board member and then appointed from the Ministry of Health and Population. She then became a founder member of the board of directors of Green City Hospital, founder principal and board of director of Yeti Health Science Academy, and then the principal of the Hope International College. She has been blessed and honored to be appointed the registrar of the Boubacar University, a government university, by the Right Honorable Prime Minister of Nepal. Being a registrar means that she was head of administration, finance, and examinations. So Pramila has hailed from Nepal, and we are very grateful for the opportunity to hear from her on empathy in the workplace.
Namaskar. Good morning, good afternoon, good evening. First of all, I would like to extend my heartfelt thanks to Susan and her teams. South African Bond Society Congress. I'm delighted to be here. Today, I'm going to talk about listening with empathy. So before talking about empathy listening, so here everyone has different stories. Don't think personally, don't talk to each other, and don't assume what others assume. So some of the problems has articulations here. Maybe it is from ineffective treatments, or maybe it is the problems of bullying, harassments, or maybe experience a bad day, or maybe you are having hard times, or maybe suffering from discomforts, or some of the news of breakup, and sick child, parents, and your spouse. This is the sum of the problems, articulations in your persons and professions lives. So some of the issues are like nutrition, health, and certain unacceptable behaviors like bullying, harassments, violence, gossip, toxic cultures, and toxic talk, role conflicts, so on. And it leads to stress, burnout, instability, anxiety, overwhelms, sadness, hopelessness, struggles, and so on. So here studies has suggested that expressing empathy is highly effective and powerful, which builds patient trust, calms and improves health outcomes. Even research also has shown that empathy and compassion to be associated with better adherence to medications, decreased malpractice cases, fewer mistakes, and increased patient satisfaction. So here today I'm going to highlight a topic about active listening and self-awareness. If there is positive increased self-awareness and high positive or connective listening, definitely it helps to increase your empathy. And if there is the high levels of empathy, definitely that leads or that will impact in your improve patient-centered cares or increase your trust levels and build rapports, increase your understanding levels, satisfactions, increase your support systems, and acknowledge. So now let me talk about empathy. Empathy is seeing with the eyes of another, listening with the ears of another, feeling with the heart of another. So here, according to these models, first I have included self-awareness and second was empathy, listening. So talking about the self-awareness, it is the main ingredients, main paradigms in our persons and professions lives. So here some of the tips and techniques are there. It helps to grow and develop your self-awareness. Now let me share some of the ingredients. That is, acknowledge your positive attributes, because each person have their own attributes. You are good for, like for examples, you are good for providing good patient cares. You have good skills for communications, skills of plannings. Only things you need to acknowledge yourself. You need to know and recognize yourselves. So another ingredient is belief system. About it, I like to share one quotation which has given by APJ Abdul Kalam. He has suggested that if you believe yourself, but also people criticize you, don't bother each and every games. Audience create sound, not from players. Be like players, increase your belief system and confidence levels. So another ingredient is create your visionary boards. Your personal and professional life, this is your journey, this is not your destination. If you are able to have such type of your journey, definitely your goals, your destination, your journey will be power, peace, prosperity, productivity, and profit. So another ingredient is you don't compare yourself with others because you made up in different unique characteristics. You have your own smartness, you have your own competency, and why to compare to others? If you are comparing yourself to others, that means you are humiliating, you are insulting yourselves. So another ingredient is don't like connect with empathy and connective type of people. In our experience, we used to come across different type of persons. Some person, they enjoy to blaming us. They enjoy to sharing problems, that called the apathy type of people. Some people, they will share problems, isolate solution, that called the sympathy type of people. And some people, they will share problem, solution, isolates, they will share our perspectives, that called the empathy type of people. You need to identify who are they. Maybe they are from your friends and families. Need to make boundaries and central lines to identify them and create your smart goals. reverse and visualize. It helps to grow and develop your self-awareness. Also, reflect yourself, stand in front of mirror and ask yourself who you are, what limitation and limitation you have. You need to identify yourself. Do meditation. It helps to connect your body and minds. Also, it helps to decrease your stress levels also, and get feedback from your family and friends, because they know about you. They care about you, they like about you, so that you'll get the accurate feedback from your family and friends. So there is the number of skills and tools are available to assist for assessments, so that you can go for Johari models. Johari model, it helps to understand your blind spots. There is a DIX analysis, it helps to understand your personality. There is the 360-degree feedback is there. There is the others number of psychometric tests are there you can adopt to know your levels of awareness, your strength. This is all about self-awareness. Next, let me talk about empathic listening. So here even data also have revealed that 45% we used to engage for listenings, only for 9%, writing 16% for readings, and 30% for speaking. So that we need to more consider, we need to hide, we need to grow skills for empathic listening here. So before having empathic listening, you need to see your attitude. Attitude is the ticket to success. Here there are some of the ingredients are there, like you need to adopt non-judgmental, non-biased attitudes, and be care and consider. If you are able to display such attitude, definitely your clients will share more information. If you have more information, definitely you have this to make plans and make messages and make the decisions. Have complete listening and desire to listen. This type of attitude you need to go and develop in your personal and professional life. So another remembers what type of listener you are. So there is the few that type of listenings habits are there. We need to make sure what type of listening are there, whether we are also adopting wrong type of listenings. So here included in the pseudo listening. Pseudo listening means you are physically available near your clients, but mentally you are somewhere else. You are not giving consultation. That called the pseudo listenings. So another stage humming listening means here you will know that your answer, so you will not give opportunity to share your clients and insulting listening, selective listening, and defensive listening are theirs. So another ambushing listening means you listen our information. After completion of listening, you will start to harm and spoils in your clients. That's called the ambushing listening. See the what type of you are a responder, you are what type of like connect type of responder or others type of responder. This have connected with 5 tiers. Tier of attack tier, self-doubt tier, void tier, detect tier, and connect tiers. Here connect tier, this is like a empathy type of tier. This is the positive or it is the good attitude for listenings, and detect tier, that is assertive type of listenings. Void tier, like this is the first type of ear. You need to make sure what type of responder you are. And then see the remembers 5 L's, that is look in the eyes of the speakers, lend your ears to the speakers, your legs should be crossed, lips should be sealed, and see that your lap is where your hands should be placed. Speak less and listen most. So here for having the empathic listening, you can go for different process, but here I have taken the UDR model process. He has talked about the 5 processes, that is hearing, understanding, remembering, interpreting, evaluating, and responding. We're talking about the hearing and listening here. Listening will take more words per minute than the speaker. That means 500 to 600 words. So that we need to make sure, we need to take care of our empathic listening. So another process is understanding. Understand we are here in our personal and professional lives. We need to see the beauty of responding, not for listen, to understand, not for replies. In this case, you need to apply the habit for effective leadership. That means you need to seek to be understood than to be understood. For example, sometimes you're in your organizations, your staff not able to perform tasks on different times. So that before treating treating them, so you need to know the actually what is happening. So maybe or your staff not able to get support from departments, or he doesn't have that skills to perform that task, or he has some others physical and family problems. You need to understand than to be understood. So if you are able to apply these models, definitely your staff will for you, your staff will for organizations, your staff will for him, and his performance, his productivity, his engagements, and his quality of service will be more. So that you need to follow the stop, slow down, and go formula. This is all about understanding. So here's reactions and response, or reply and response. If you are taking the pause times, your response will be positive. If you are not taking the pause times, it might go the unwanted outcome. So that you need to see the breathing, ask yourself and see your ego and see the consequences for having the positive response. So another process is remembering. This is also important ingredients. In this ingredients, if you are an actor within the minutes, that will take the 50% of effectiveness. If you are acting after 8 hours, that will take the 35%. If you act after 2 days, it will take the 20% of effectiveness. So you need to make sure when you are going to respond, when you are going to act. For remembering your skill, you need to see your review, practice, and recite. For remembering, for increase your practice, even Krishna and also they used to practice to increase their performance. So they used to practice and they used to take the feedback. Yes, 20 minutes of practice, that is more effective than the 20 hours of thinking. So that we need to increase our practice. We need to increase our performance for having the positive outcomes. So another, see the interpreting accurately. So here all the time verbal communication will not be complete. There is the approximate 30% of information that will complete after consultations of the non-verbal communication. So that we need to see the non-verbal communications, like see the tone, voice, poses, facial expressions. And another process is evaluating, see the guidelines and validity and response in situation. This is the process which Hewlett has suggested this one. So here's empathic listenings or active listening that should be have photography approves, like hide aim with the stickers. See the stickers aims. Stickers you think they are very important, they are vital for you. You need to treat like kings. You need to give more concentrations and high frames. That framework should be considered of your client's approach and focus that should not be disturbed. You need to provide more focus what your clients supposed to share. And see the Chinese character of listenings. This diagram has suggested that ears you need to tune the tone, pause, modulations, and spoken words. And then see the eyes. As you need to observe the different nonverbal communications, like body language, expression, tone, body poses, like that. And then your attention that should not be get disrupts from or interruption from others. And mind should be opens that should think in critical ways, and your heart should be compassionate. So you need to apply your models. That means explores some of the verbal, non-verbal communications and empathic questioning and response. For that, you need to apply the effective leadership 5 habits or effective individuals 5th habit, and acknowledge that should be progressive. That should be yours clients' perspectives. And here you should know empathy is the superpower of our personal and professional lives. Empathy, it can be cultivated and developed. Empathy, it helps to increase or you can create the good teams. Here, team is not a group of people who are working together. So team is a group of people who are trusting each other. So that empathy, it helps to increase our trust levels and higher morals, low stress, and it helps to connect and levels cognitive emotions and behaviors. Even Albert Einstein also said that everything is energy. There is the energy and emotions, they have associations. If there is the high energy frequency, that means enlightenment, happy, joy, that lead to or that increase your power, your peace, your prosperity, your productivities and profit. If there is the less frequency, like your anger, frustrations, stress, that will lead to that will conflict your sorry, your home life and your office life. So here, study also has shown that training it has highly associated with the empathy, increased empathy. I'm sure we should not never underestimate the healing effect of the beauties which has given by Florence Nightingale. Here, Gautam Buddha has shared one quotation: speak such a way others like to listen such a way others like to speak. Here, actions speak louder than words. Thank you.
Thank you so much, Pramila, for a very inspiring talk. Yeah, so often we stand there and we hear, but we don't listen. And then sometimes we find ourselves in a situation where we listen, but we don't hear. So thank you for teaching us how to connect with ourselves and giving us actual practical tips how to tune in to make sure that we are hearing what the person is saying so that we can display the caring and the attitude. And often we find that these are our values that we portray. And as nurses, we often care so much for our patients, and our empathy, it just overflows. So thank you so much for a great talk, Pramila. Our next speaker is Sister Anke Eisel, who will be presenting the cheat sheet for burn patients for non-burn nurses. We have seen that during COVID that as nurses we are thrown into positions or into places where we haven't really been before. So we would find myself, a wound expert, being put into a theater or into an ICU, which is outside of your comfort zone. So what Anke then did is, very cleverly, because she is a nurse, she has then developed an easy how-to guide. So I'm just going to read you Anke's bio, which again is very well acclaimed. So Anke Eisel received the MCA degree in critical care from the Department of Nursing Science at the University of Pretoria in 2002. She fulfilled her nursing roles at various health facilities in Gauteng and Mpumalanga, South Africa, in clinical, community, and critical care nursing. In 2018, she joined the humanitarian organization Doctors Without Borders as a field worker in Asia and in the Middle East, where interest in burn care was ignited. Of course, interest is improving patient experience. Of special interest is improving patient experience and clinical care of burn injury patients in burn units at Life Cosmos Hospital in Imalahleni, Mpumalanga, South Africa. Anke, thank you, and we look forward to your talk.
A cheat sheet for quality nursing care of burns patients. Presented by Anke Eisel, registered nurse at the burns unit of Life Cosmos Hospital in Witbank, Mpumalanga, South Africa. Burns care is complex. In our unit, we pull a lot of people and a lot of actions to make burns care work. In our unit, we promote a homely environment and our care is patient-centered. Rehabilitation starts on day one. Our nursing activities are done with rehabilitation in mind. Anything that a patient can safely do for himself, we allow him to do that for himself. Teamwork. We have a large multidisciplinary team that work together to help our patients heal. Clinical excellence is the glue that keeps all these circles together. Our aim is to help the burn injury patient to heal as fast as possible, as well as possible, to integrate into his home, family, and work life as quickly as possible. When I started working with burn injury patients, it was completely new to me. It was unlike any other patients that I have ever come in contact with in my career as a nurse. I felt overwhelmed. The care these patients needed was different, and the way things were done in this unit was very different and unfamiliar to me. Prior to working in this unit, I was a field worker for an international humanitarian aid organization and had experienced nursing in Asia and the Middle East. There I learned that a different way of working can also be a good way of giving care. I quickly realized that I needed to know more, much more. So I started reading everything and anything burn related. Google Scholar became my new best friend. And after all this reading and research, it led to a quality nursing care for burns document. And after many drafts, it became the cheat sheet. The cheat sheet became a single page, printed on both sides, and served as a reminder checklist of the quality of care of our burn injury patients. It was laminated to be easily cleaned and used as a tool at the patient's bedside. Preparation for admission is first on our cheat sheet, our CS. The admission process is quick and effective if everything is ready, working, and close at hand. Being disorganized and seemingly unprepared does not promote a good first impression. The first impression our team makes on the newly admitted patient is the basis for our relationship with him for many days. It is easier if that first impression is good. The admission preparation section of the CS contains all the things that we need to remember to prepare before the patient comes to us. We need to zero the bed, we need to adjust the room temperature, and we need to gather all the documentation that we need to admit the patient fast and effectively. And since we are still in the middle of the COVID-19 pandemic, always remember the PPE for the COVID risk. The nursing admission section of our cheat sheet is the biggest and the busiest part of the paper. Just as the first 24 hours after admission for a major burn is the critical time, and it's also the busiest for our team. There's a lot of things to remember in that first day. The left side column indicates the action, prescription, investigation, or consult that must be done. The middle column describes it in a little bit more detail, and the right-sided column reminds us of the nursing care specific points related to the actions, prescriptions, and investigations. The left-hand column reminds the team of the TBSA that must be done, the fluid resuscitation, the 12-lead ECG, the medical prescription, and it also includes analgesia, anticoagulants, bronchodilators, vitamin C regime, and trace elements if that is applicable to the specific patient. COVID-19 risk must also be assessed and the appropriate isolation of the patient must be done. Next is the investigations, the blood test and the x-rays, and the nursing care specific things related to these investigations. Screening is always important, especially for community-acquired infections and infections that can severely affect the patient's recovery. Thermoregulation is critical for major burns, and it just reminds us of what must be done and when. Consults is significant. Physiotherapy, nutritional, and psychologist in the first 24 hours. The assessment is the next section in our cheat sheet. Primary and secondary assessment. It reminds the nursing team of the ABCs, deformity and exposure. And in the burns unit, we must complete the Wallace Rule of 9, and that the fluid resuscitation must be established. Secondary assessment, pain management must be done. Urinary catheter insertion for accurate urinary output every hour. Nasogastric tube, IV access, x-rays, blood test, and tetanus toxoid. and to consider the mechanism of injury and the comorbidities that would have an effect on the nursing management of the patient. The quality of care section reminds our nursing team of the quality care points that easily gets a bit lost in the busyness of a critical patient or in the day-to-day running of the unit. Communication and information. To communicate with the patient and the family and to give the visitor information sheet. To allow time for questions and establish an open communication line with the patient and the dedicated family member. Infection control is so critical to burns care. Proper hand washing at the start of the shift and at the end of your shift. Hand hygiene between patients, to wear an apron and gloves inside the room at all times. Reverse isolation to protect our patients. Multidisciplinary team to perform hand hygiene when entering the unit and between patients. And as always, the COVID-19 risk. The patient is to wear a surgical mask when he leaves the room. Visitors. This point just reminds the nursing care team of our visiting time rules. Medication administration is important. And in our unit, we have a dedicated normal saline line that is used only for medication, not for fluid resuscitation. And we would spread the administration times throughout the day to prevent the mixing of medication. The clinical nursing management section contains information to our nursing team with regards to how our unit will manage optimal oxygenation, hemodynamic stability, positioning, and just a reminder again about the hemoglucose test, the body temperature, the pain control, the assurance and comfort to the patient and the family. Nursing management day 2 reminds our nursing team of what must be checked on day 2. Fluid resuscitation must be adjusted. Investigations must be repeated. We must make sure that the patient and the family has received counseling, and the infection prevention and control bundles must be checked. The CAUTI, the CLAPSI, and the VAP bundle. Nursing management day 3 reminds our nursing team of things that must be checked on day 3. Have we started treatment for hypermetabolism? Are we reaching the patient's nutritional needs by giving nutritional supplements? Socializing. Has the family visited? Has the patient received toiletries and snacks from home? Communication. If the patient is able to manage his phone, has he got his phone? Does he have a charger? And is he communicating with his family? Elimination. Has the patient had bowel action? Early mobilization is so important for burns patients. Have we done it? Can we give positive reinforcement? Can we celebrate the goals that the patient has already reached? Analgesia, have we changed from IV to oral, if it's at all possible? Infection control, are we managing the intravenous lines aseptically? Are we doing hand hygiene? And are we changing the lines every 3 days? And medication administration again. To check the plan for medication administration throughout the day and make sure our lines are changed. Nursing management on day 5 and 7 is to remind the nursing staff about skin protection, to start health education, and to keep track of the infection control measures. On day 7, it's important to review the level of care so that it can be adjusted on the internal hospital systems. The last part of our cheat sheet pertains to the long-term care of our burn injury patients. And it contains important things that our team needs to remember for our long-term patients. Our homely patient-centered care and our homely environment, that we will allow the patients to make their own tea and coffee when they want it. We allow them to sleep in until breakfast on non-theatre days, and that we order blood tests at 8 at night and not at 4 in the morning. We are also reminded that we can spend non-clinical time with the patients visiting them to break the isolation room loneliness. Communication with comment cards. We give out the comment cards weekly and not only on discharge, so that we can identify problems and complaints early on, and maybe address them before the patient is being discharged. Stress management, play therapy. We must continually manage the stress of the patient with our homely environment and some games. Rehabilitation that started on day 1, continue until discharge. And we encourage the patients to do self-care activities. If the patient is able to make his own bed, he is allowed to do it. The patient needs to sit in the chair, and they're allowed to walk around the unit and even around the hospital. The cheat sheet is a work in progress, and it will always be updated as new treatment, procedures, and research becomes available. It is a tool that our team use to always improve our quality of care. During the COVID-19 pandemic, our unit was utilized for critical COVID-19 positive patients. And now that our unit is utilized for burn patients again, our own cheat sheet gets us back on track for quality nursing care for our burn patients in our unit.
Thank you so much for your presentation, Anka. It was very, very informative. And I like the practicality of it. I just have a few questions that we received for you. So with you using the cheat sheet, did that improve your audits and your overall patient outcomes? Anka? Can you hear me? I think we're having a problem with your audio.
Yes, I'm not hearing you so very well. I think what you asked is if the cheat sheet helped us improve the way we worked. Yes, it did. It's just reminding our staff that on day 3 this must be done, day 5 that must be done. So when audits and quality comes by, that our quality has improved and our audits has become better, because we have a checklist, a reminder list, so that we don't forget these smaller things that sometimes gets lost if the unit is very busy.
Yeah, we've seen in the literature, they say, for instance, when a patient is going to theatre and a checklist is in place, it just simplifies things a lot. So yeah, well done on a great initiative. And then I have another question. During your presentation, you were saying that your unit aims to make or try to create a homely environment. And often we find that with burn patients, they are long-term patients. So how does that work? Does it help to reduce the codependency? Because often we know that if patients are there for long-term, they've got this whole codependency going. They don't want to do stuff for themselves long after they have regained their functionality. So how do you ensure that your patients, you just encourage from day one, but then they might perceive it as you're not wanting to help them? So how do you balance it?
I think it's a team effort. We just do it. And the patient that's been there for 20 days is the example to the patient that has been admitted 3 days ago. So they see the other patient walking around, maybe making his own tea or coffee, and then they realize that I can also do it for myself. It's like the in-house support system between the patients. If that guy can make his bed, then I can make my own bed.
Okay.
So as a team, we just continually do it, and it just happens.
Okay, that's good to know. That's definitely something that we can all take away from you and from the presentation, as well as the cheat sheet. I mean, it's amazing that it gives you the guidelines day by day, because if it's not written, it's not done. So now there's no excuse.
Yes.
Thank you so much, Anka, for a great presentation. We thoroughly enjoyed it.
Thank you, Ethel.
All right. So I would like to then introduce you to our next speaker, who is Dr. Alette de Jong, and she will be speaking on pain management and burn nursing across the ages. Alette is from the Netherlands, and I will read you her bio. Since 1985, Alette has been involved in burn care at a burn center at the Red Cross Hospital in Breakaway, the Netherlands, as a registered nurse and a researcher. She studied nursing science and obtained a PhD degree. She initiates and performs research in the field of burn nursing to improve the quality of nursing care. The research focus is on person-centered, pain-free wound care, including pain measurement and comfort-increasing interventions. To connect daily practice, education, and research, implementation of research results in nursing practice and teaching at the Dutch Burn Nursing course as part of her responsibilities. She is, among others, board member of the European Burns Association, member of the Nursing Honor Society of Sigma Theta Tau International, and a member of the Dutch Academy of Burn Nurses. Thank you, Alet.
Dear colleagues, good afternoon. The Red Cross Hospital in Beverwijk, the Netherlands, is a medium-sized hospital, and the burn center in this hospital is the first in the Netherlands and origins from 1974. Many victims with extensive burns from the nearby steel factory were admitted to the regular wards of the hospital at the time, and doctors and nurses recognized that a specialized burn center was necessary. Meanwhile, the burn center has been developed by the European Burns Association certified burn center. We have 25 beds, and this is the current team of nurses. And as you all know, nurses play critical roles in team-based care. Since nurses provide 24 hours care per day, they are in a central position to survey the total care process and to coordinate all care activities around the patient. And nurses are therefore the backbone to burn care. I've been working in burn care since 1984. I started as a student and have not left the field since. I've been a nurse researcher as well since almost 20 years after obtaining a Master of Science in Nursing degree. And my research is focused on person-centered pain-free wound care, including pain measurement and comfort-increasing interventions in order to improve the quality of nursing care. I've met your president, Ethel Andrews, in 2016 during a meeting of the research committee of the International Society for Burn Injuries in Miami. And thank you for inviting me at your Congress. Since Florence Nightingale, nursing has gone through many stages in its search for a professional identity. The International Council of Nurses defines nursing as providing care and comfort to enhance healing and well-being. It includes care of individuals of all ages and in all settings, the promotion of health, prevention of illness, and the care of ill, disabled, and dying people. Nurses' work is complex. While doing visible tasks, nurses also assess patients, whether they are progressing or developing complications. They initiate interventions or call for consultations. They provide patient and family education, prepare patients for self-care after discharge, and provide psychosocial support. I had the privilege to attend my first ISBI Congress in 1992 in Singapore. And to my surprise, nurses did present here even on their own research. One of the speakers, Janet Marvin, had impressed me most. She presented on research into pain management, and she also identified key competencies of burn nurses and stated that their future lies in education and research. She is certainly not the only pioneer, but her work was crucial to burn nursing. So what happened before and after Marvin's work? To get an impression of developments in burn nursing, the literature was searched. And the topics of the papers can be roughly divided into education, research, and practice. So let's take a closer look into these fields to identify achievements and future goals. To start with the topic education. Georgiana Sanders attempted 100 years ago to educate nurses in burn care, and she included practical advices in her manual for nurses. And pain management and wound care were found the most important care problems at the time. The first articles on education were published in the 50s, aiming to share knowledge that was based on case studies. Since the 70s, education has been developed gradually, varying from guidelines, wound care, and plastic surgery courses to recognized training. Currently, the Dutch burn centers facilitate an 18-month lasting burns nursing course developed by and for nurses, and it is now recognized by the College of Dutch Healthcare Studies. Also, increasing the number of nurse scientists, nurse practitioners, and bachelor's prepared nurses will increase the body of burn nursing knowledge. Extensive studies recently published in the British Medical Journal and The Lancet provide strong evidence that when nurses are not sufficiently educated, patient safety is at risk. A workforce with a greater proportion of bachelor's prepared nurses, for example, is associated with lower mortality, fewer complications, and shorter length of stay. Burn centers should therefore invest in a learning culture that, besides, optimizes work and patient satisfaction and decreases staff recruitment and retention problems. The next topic from the literature search is research. The profession becomes stronger by founding daily practice on research instead of routine and habits. Research in nursing is not new. Florence Nightingale already devised clever ways of presenting research. Her best-known graphic is this pie chart showing the number of losses and their causes in the Crimean War, and the pink wedges represent wounds. In the 80s, a start with a research program was made, and incorporation of research findings in daily practice was initiated. Colleagues from the USA published research priorities. These priorities were pain management, staff recruitment, retention, and workload, psychosocial issues, and wound care. Subsequently, more research got published, predominantly on pain management. When taking a closer look into this research, it shows that pain management is important for many reasons. For example, inadequate pain management increases pain resistance. It triggers mechanisms that may lead to increased sensitivity to pain over time. Pain may also increase the development of delirium and limit the extent of self-management. Adequate individualized pain management should therefore have high priority in daily burn care practice. To evaluate the effects of tailored pain management, pain should be measured. From earlier research, we know more about pain measures, and the first choice is the patient's self-report. Many self-report measures are available. For adults with burns, scales with the best clinimetric properties are the visual analog thermometer, the visual analog scale, and the verbal numerical rating scale. They can be used interchangeably. Currently, the most appropriate methods to manage pain is a combination of at least 2 types of medication in appropriate doses and administered at the right moment, combined with additional evidence-based non-pharmacological interventions like breathing techniques, music, aroma, or virtual reality. Some groups of patients are, however, unable to self-report. Structured pain behavior observation measures are therefore suggested. Research shows that when 2 nurses simultaneously assess pain on a 0 to 10 scale of a 0 to 4 years old child, the ratings correspond less well when compared to ratings obtained with structured behavior observation. By using a valid and reliable scale like the Comfort B, we are now able to evaluate pain in young children. And factors that seem to positively influence pain when measured with this scale include early pain treatment by the referring hospital, the application of hydrofiber dressings, and the presence of parents. We do not yet have reliable and valid measures for ICU patients with burns that are also unable to self-report. Existing pain observation measures for general ICU patients, like the behavior pain scale and the critical care pain observation tool, include facial expression. We currently investigate if we can reliably observe facial expression through facial burns, crusts, and bandages, and if the scales are suitable to assess procedural pain. We are now in the data analysis stage, and the results seem promising, especially for the CPAT. We have found that high background pain and anxiety are predictors for high procedural pain. Therefore, we propose the measurement of anxiety for pain. The burn-specific pain anxiety scale rates self-reported pain-related anxiety, especially regarding wound care. After developing a 9-item scale, we now have validated the 4-item scale. Furthermore, there is a lack of appropriate measures for our elderly patients suffering from delirium or dementia. Proposed instruments are the Rotterdam Elderly Pain Observation Scale and the Pain Assessment Checklist for seniors with severe dementia. And research into the kinematic properties needs our attention, because the better pain is measured, the better it will be managed. Regarding research for the future and to expand the future generation nursing scientists and researchers, we may create a pool of national and international networks. Alliances between burn nurses globally can engage nurses to be more involved in research and publication. I believe we should form an international expert group of interested colleagues, because an international community is stimulating and we could learn so much from each other. And then the last topic of the literature search practice. A core activity of burn care nurses is wound care of wounds with large surfaces on difficult to bandage locations in different stages of the wound healing process. But there is more than wound care. Daily practice, according to the literature, has been developed from caring for patients with burns by trial and error to a valued specialism. In the near future, the changing patient population and technology will influence our profession. We will meet more patients with multimorbidity and chronic diseases. Regarding technology, we need to get used to work in advanced patient environments, but also get involved to develop them. Get used to wearables and possibly even robots. Development in practice can also be seen in other fields. For example, in role and competence development and in positioning. Many competencies and roles have been reported. Nurse practitioners, aftercare and research nurses, educators, and so on have been introduced in burn care. New roles are associated with new responsibilities, autonomy and a voice in decision-making and ownership of the profession. In nurse-led pain management, fluid resuscitation, and outpatient clinics, and in process optimization programs, nurses are the owner of nursing processes. In summary, we have done and have to do many things to optimize nursing for our patients. We have to educate the next generation burn care nurses and to invest in nursing research in order to generate a foundation for excellent burn nursing. Only then we can continue to give the patients the quality they need and that they can live a meaningful life after burns. And it would be great if we could do that together. So this was my talk. Enjoy the Congress and thank you so much for your attention.
Hi, Let. Thank you so much for a great presentation. You should have given me the heads up. You were going to show my picture, like. So, all right. So, yeah, thank you for the summary as well. I have a question to you. We wanted to know, so in South Africa, burn nursing is not a specialty yet. So firstly, first question would be in the Netherlands. I'm assuming that you do have it recognized by your regulatory body as a specialty. Alet? Can you hear me?
Yeah, the line is very bad, but you were asking something about the course we have, the recognized nursing course?
Yes, so what I wanted to ask, your regulatory body in the Netherlands, do they, even though you are working in a burns unit, for instance, it might not be seen as a specialty. So you would maybe be considered an ICU nurse as opposed to a burn nurse. So in the Netherlands, does your regulatory body?
Yeah, there is a very bad line, but maybe the question is if you should be working in a burn center for doing this course, then the answer is yes.
Okay, all right. And then the other thing that that we wanted to know about is like with regards to the, so you have an existing course for burn nursing in the Netherlands. Alet? We don't seem to be hearing each other.
Evan? I cannot see you anymore, and I can't hear you.
Okay, can you hear me now?
Now you are back.
All right.
Yes.
So the question that I wanted to ask is, do you have a specific course for burn nursing?
Yes. Yes, it's a 1.5 year lasting course and with lots of theory, but also, you work in daily practice, and we also do exchanges with other burn centers in the Netherlands.
Okay. All right. And then if we wanted to like go on an exchange program and visit you in your country, is this course of yours open is it only for people working in the Netherlands, or is there fellowship being offered, for instance?
Oh, that is a very interesting question. So if we are going to manage this, you will be the first. And I think this is a great challenge. And we can do this to start with online for the theory. And yes, I see some challenges in cooperation in educating nurses.
Yeah. Okay. No, thank you. So I will definitely sign up for it. And I can imagine a few of my colleagues also thinking that, yeah, this would definitely be an area of interest.
Yes.
So thank you so much, Alette, for your time and for availing yourself. We really, really appreciate it. And yeah, you have highlighted very important things. Often we find that we don't concentrate on the pain that the burn patient is experiencing, and post-traumatic stress then becomes something after that, like an afterthought in a lot of the institutions. So thank you so much for the research and for highlighting it. And I like the one point where you said that if nurses are not properly educated, we're actually a danger to our patients. And that's very, very true. Alette? All right. So thank you, Alette, for joining us, because I think
let's have contact for the future. Welcome.
All right.
Okay,
bye.
bye.
Thank you. All right. So we have come to the end of this session. We would like to remind you to please stay tuned. We have Trade addressing you immediately after this. And then during your breaks, if you can please go to the different booths. The sponsors have made this very possible for us, and it's just a courtesy for us to make sure that they get the interaction also as well. So please, we will ask you that you visit the booths. There's the lucky prizes. We actually have 5 prizes up for grabs. So we would really, really appreciate it if you can go to the booths and interact with the representatives there. But please stay tuned for the sponsorship infomercials that will be on now.
Have you ever noticed that whenever a medical breakthrough is achieved, people call it radical, revolutionary, unprecedented? At 3M Healthcare, we call it something different: science. When a surgical procedure goes well with less risk of complications, 3M is there. When a person is able to look at themselves differently, 3M is there. When the right care is administered and lives are restored, 3M is there. 3M is there. When a doctor can put the keyboard down and instead focus on their patient's every word, 3M is there. 3M is there. Even when a family sits down to a nice meal together, 3M is there. 3M is there. Armed with a passion and commitment to science, 3M Healthcare is helping make better health possible for people next door, and around the globe. Science is our pursuit. Improving lives is our purpose.
There's more than one type of wound. Some can be healed, some can be prevented. Some can only be managed. Because there's more than one type of wound, we need more than one type of solution. When it comes to the healing process, one size doesn't fit all. Your patients are dealing with unique challenges. And while you're helping them, we are helping you. We are standing by your side, 24/7. So you'll receive the support. We are offering extensive world-class education and training, so you can feel more confident in the latest products and techniques. We are creating innovative solutions designed around your challenges, so you can help improve the outcomes for all your patients. Patients with wounds that need to be treated with negative pressure wound therapy. Patients with closed surgical incisions that need to be protected from surgical site complications. Patients with chronic wounds that need ongoing care and management. We are doing it together. The people behind the curtains. The people behind the technology. We are transforming healing. And we're doing it with science.
Elise is used to treating patients with acute or chronic wounds with VAC therapy. Today, a new clinically effective therapy exists, VAC Veriflow therapy. It combines the benefits of with the benefits of instilling topical wound solutions to clean and moisten the wound. Elise can choose from different types of foams depending on the wound. For example, in the event of fluffy wounds, when surgical debridement may be delayed or is not appropriate, the VAC Veriflow Cleanse dressing facilitates the removal of thick exudated infectious materials thanks to its honeycomb structure. Elise applies VAC Veriflow dressing in the same way as a traditional VAC therapy. She prepares the wound according to her hospital care protocol and applies the 3M Cavalon no sting barrier film wipes provided inside the kit to protect her patient's peri-wound skin and allows it to dry completely. She applies the pre-cut foam in such a way as to fill and cover all the surfaces of the wound without pressing it down. For VAC Veriflow Cleanse dressing, the honeycomb contact layer is placed directly in contact with the wound and then covered with one of the filling layers depending on the depth of the wound. Then Elise trims the VAC advanced drape to the appropriate size. She applies it, avoiding folds. She cuts a circular opening the size of a €2 or 10p coin in the field. She removes the backing layers of the VAC pad and applies it directly over the opening. Elise prepares the VAC Alter therapy unit by connecting the canister and fixing the VAC Verilink cassette, which she connects to the solution bag, which will be to be instilled into the wound bed. She connects the first tube into the VAC Verilink cassette and the second to the canister previously attached on the VAC Alter therapy unit. Elise adjusts the default setting on the VAC Alter therapy unit according to the medical prescription. The unit is set by default to an installation cycle every 3.5 hours with a soak time of 10 minutes and a negative pressure of 125 millimeters of mercury. She can set the instill volume manually by adjusting the volumes of wound according to the amount of foam used, or with the fill-assist, which helps to determine the exact instill volume by allowing Elise to manually start and stop installation. When changing the dressing, Elise uses the dressing to facilitate the removal of the foam. VAC Veriflow therapy is the evolution to VAC therapy. It facilitates and may help improve the effectiveness of negative pressure wound therapy through regular and automatic wound cleaning as compared to VAC therapy.
Our world is rapidly changing. Around the globe, communities are developing new ways of managing their life, education, and health. Coronavirus has rapidly driven change, transforming how we connect and interact with our healthcare. When it comes to the needs of wound patients, some things are not working well. Despite innovations in treatment, patient outcomes are less than ideal. Wound patient numbers are still increasing, impacting working age adults as well as older people. Budget pressures are making it difficult to access more effective specialist products and care. Inconsistencies in diagnosis and practice are compounding these issues. We understand the daily challenges you face managing patients with wounds. Together, we have the opportunity to establish new standards of care. We're seeing greater adoption of early intervention strategies with opportunities for further innovation in patient-led care. At Smith & Nephew, we're committed to improving the lives of patients. Alongside our customers, we won't settle until we've solved the challenges of preventing and healing wounds, because they hold back too many lives. We're developing better ways of improving outcomes for patients, ensuring the right treatment for the right wound. We're continuously searching for ways to improve how care is delivered. Your challenges are our challenges too. By meeting and exceeding you and your patients' needs, we can make real change. Continually shaping what's possible in wound care.
Acticoat, nanocrystalline silver-coated antimicrobial barrier dressing range. Acticoat barrier dressings demonstrate clinical efficacy in the treatment of infected wounds. At first glance, Acticoat dressings may appear to look similar to other silver barrier dressings, but deep within the structure we can see why Acticoat nanocrystalline technology is so unique. The deposition of silver impacts the efficacy of the dressing. The more silver that is available in a dressing, the more pathogens can be killed. When we look more closely, we can see there is a visible difference in the silver coverage of Acticoat dressings compared to other silver dressings. On an Acticoat substrate, there is a continuous coating of silver, compared to other silver barrier dressings that show a less dense deposition of silver. Nanocrystalline silver has a high surface area, so can achieve a sufficiently high Ag+ concentration to be rapidly bactericidal in the presence of wound fluids. The unique construction enables more silver to come into contact with the wound fluid. Within 30 minutes, positively charged silver ions come into contact with bacteria, disrupting the cell wall and cell membrane, denaturing the proteins and enzymes, preventing respiration and inhibiting DNA synthesis, resulting in cell death. The challenge with the use of low-dose silver dressings is that active silver binds to many components found in wound fluid, such as RNA and DNA, chloride ions, devitalized tissue, proteins, and other organic material. This leaves little to no available Ag+ to kill bacteria. So it's important that the silver dressing delivers enough silver to sustain the Ag+ concentration needed to be bactericidal. A marked difference in the speed and extent of kill was observed. This example shows EMRSA. As the bacteria die, they turn red. You can see how quickly and effectively Acticoat starts to kill. Acticoat has broad-spectrum antimicrobial activity and is proven effective in vitro against a broad spectrum of gram-positive, gram-negative bacteria and fungal wound pathogens, including strains of MRSA. Acticoat makes a real difference to patients. It reduces bacterial burden, helps prevent progression of wound infection and wound invasion, leads to faster reduction of clinical signs of infection, has less risk of resistance, is proven to provide an efficient antimicrobial barrier. Acticoat barrier dressings come in various different formats, which all contain nanocrystalline silver. Flexible, absorbent, or conformable, each Acticoat variant is developed with properties specific to its required use. Acticoat broad-spectrum antimicrobial barrier dressings with unique nanocrystalline silver are proven to prevent and treat wound infection.
Thank you so much for that. Your infomercials was very, very informative. We've definitely seen, and we're glad to see that Baxter Band is back. We would also then like to encourage you to now join the main session where the abstracts will be presented. And thank you so much for your time.
Somewhere beyond traditional thinking, beyond standard treatments, is a place that bridges where we've been to where we're driven to be. It's where innovation that saves and sustains lives meets the providers who make it happen. Where our ability to manage illness expands to reach patients with limited options. Where we address complications before they become life-threatening. Where we're not only treating diseases, but also discovering smarter ways to prevent them. This is our place, where we come together to write our greatest chapter as a visionary company operating at the center of global healthcare. This is the intersection of our boldest possibilities. This is the new Baxter.